good afternoon, good morning, good whenever part of day it is for you that are watching this. I'm Stephanie Walker, and I'm the statewide lead for the Texas Sensory Support Network, blind and visually impaired. I'm here with my co-presenter, Susie Tiggs, and I'll let her introduce herself in just a moment. And we are going to go over deciphering eligibility for students with suspected hearing or vision concerns. There is a QR code in the bottom right-hand corner. Susie, you want to tell them how to use that?
Okay, if you have a smartphone, then what you do is you open your camera on your smartphone and you just put it up to that and boom, it should automatically open up. If you do not have a smartphone, or at least you don't have it handy with you, below this we do have a link called a bit.ly, and it's bit.ly/TEDA/DHHVI. That's all lowercase. Again, bit.ly/TEDA/DHHVI. And the QR code and the link will both get you to a live binder that will have a copy of this presentation as well as any of the resources that we reference. One of the nice things about live binders is that they are a living resource. So next week, if we find out some new things that we didn't have in there, we can keep adding it to it, and it will always grow and always have updated stuff. There is a charge for you to use our live binders. However, if you come across documents or resources that you think should go in there, you have to send them to us. So that way we are crowdsourcing all of the great information that's in the live binders. My name is Susie Tiggs. I am the statewide lead for deaf and hard of hearing services part of the Texas Sensory Support Network. Stephanie and I present together a lot, and we normally start by saying you can remember the two of us because Stephanie does the eyes and she's got sunglasses on, and Susie does the ears and normally has big earrings. Well, since COVID, we don't go outside, so we don't need sunglasses, and microphones and everything, headphones with Zoom, don't do well with the big old earrings. So you'll have to wait to see us in person to be able to figure out who does what. Okay.
Wonderful.
Yes. Let me, there we go.
All right, so we start every presentation with TEA's True North Statement. Together, we are committed to high expectations and strong systems that achieve equitable outcomes for every student with a disability. I'm sure you've heard this a few times.
So there's a few things that we want to touch on today, and we may end up adding in some additional information as we feel like we may need some clarification. But overall, we really want to make sure that you leave here with a good understanding of what the components are of eligibility for students who are deaf or hard of hearing or students who are blind or visually impaired. We've also included in some information about students who are deafblind. We want to talk a little bit about the role of the teacher of students who are deaf or hard of hearing, the TODHH, the teacher of students who are blind and visually impaired, TVI, and what their role is in the assessment and that whole collaborative part of helping to get our students qualified and eligible. And then we also want to talk about the special factors forms, the supplements that are part of the ARD packet for DHH students and VI students, and explain why we need those, what importance they are. So this is the first section. We're going to talk about evaluation, and we're looking specifically at the evaluation that has to do with initial eligibility to begin with. Some of what we're going to be talking about, we'll talk about further 3-year reevaluations, our FIE, our full and individual education assessments. But to start off with, we're talking initial.
And before you move on, Susie, we might want to give them a little bit of a heads up that we are going to skip a little bit of this initial evaluation because we're not going to talk about all of those pieces that come before the initial evaluation until the end, and everybody really understands what it means to qualify as deaf, hard of hearing, and visually impaired. And then we'll go back and talk about potentially eligible or students that we have a hearing or vision concern over. And what does that mean? And how do we define that in our local LEA?
Thank you, Stephanie. I had forgotten that part. Okay, starting first with deaf and hard of hearing. You may be more familiar with the term auditory impairment, or AI. Senate Bill 281 states the avoidance of using auditory impairment and replaces it with deaf and hard of hearing. This was a Senate bill that came out in the last legislative session. Only the way it was written, it says that it only needs to be replaced in new statutes and resolutions. So at this point, all of our IEP paperwork, all of our Texas Administrative Code, Texas Education Code still does say auditory impairment. We would really like to encourage you to start using deaf and hard of hearing, either in combination with auditory impairment or instead of auditory impairment, just so that you get in the habit. At some point it will change. And in all of your IEP paperwork, any of your assessment reports, or in your deliberations, feel free to put deaf or hard of hearing in there. These are the definitions based on IDEA. IDEA separates deafness, deaf and hard of hearing, into two different pieces, one deafness and one hearing impairment, with deafness being students who have a much more severe hearing difference, and it causes just a delay and impairment in the processing linguistic information, and that's with or without amplification. And then the other component of that is it has to adversely affect child's educational performance, which we're going to talk a little bit more in a little bit. Hearing impairment are those students who maybe don't meet that criteria. Maybe they don't have all of that impairment in processing linguistic information. However, they have a fluctuating hearing loss, maybe a permanent hearing loss, but it's not as severe. They separate the two. In Texas, we combine them together, and we just say if a student meets the criteria for deafness or hearing impaired, then they do meet that auditory impairment, deaf and hard of hearing. Traditionally, we have three pieces of the assessment of the DHH portion for eligibility. Traditionally, they've been called the Part A, the Part B, and the Part C. Those are the names of forms. They're not the names of the evaluation. You may or may not know this, but vision, I don't know if it even still does, had a Part A, Part B. Autism does. Multiple of the disabilities have Part A, Part B. And if we say, Mom, please go take your darling son for a Part A evaluation, Mom's not quite sure who she's going to make that appointment with. We really want to start changing the terminology. Instead of saying Part A, Part B, Part C, they need to be called the otological, audiological, and communication assessment. That's what is actually written in Texas Administrative Code as well as Texas Education Code. That first piece, the otological examination, is done by an otolaryngologist, also known as an ENT. It is possible to go with a licensed medical doctor if an ENT isn't reasonably available. We're going to talk about that in a moment. The audiological evaluation has to be performed by a licensed audiologist, and it needs to address what the child's potential for communication through a variety of means. We're going to talk a little bit more about that too, because that sometimes is problematic in our paperwork. This is just a glance at the otological form. I'm not expecting that you are going to be able to see this, and I'm not going to read it to you. I just want you to I know that you have seen them before, so I wanted to be able to attach it to this. This is to be completed by an ENT or a physician. I'm going to talk about that next. It's only required once for eligibility. When we do the initial eligibility, we need to do an otological. It is not required for any of the additional every 3-year reevaluations. We do not need an updated otological unless the student has been qualified as a student who is deaf or hard of hearing based on a conductive loss, one that often can be fixed. Significant ear infections, maybe some surgery that was needed. If the ENT indicated on the form that there could be some improvements to the hearing, then we definitely want to follow up with an additional otological. Any medical changes that are needed, the audiologist is required for their licensure to have an updated otological for new hearing aids. So that may be a determination. If you're not quite sure whether you need an updated otological, check with your audiologist to find out. The otological is the responsibility of the local education agency to pay for. So if mom or dad can't take the child or don't have the money, whatever, it is the school district's responsibility ultimately to get that, however that needs to happen. So one question we get asked a lot, an otological exam performed by an ENT or by a licensed medical doctor with documentation that an ENT is not reasonably available, that's the exact terminology in Texas Administrative Code. And the question that we often get is, what does reasonably available mean? And that is a real good question. So thinking about some of the situations we run into as we're getting otologicals for our students, it is not unusual for us, either us as the school or the parents, to call to set up an ENT appointment, and the first available one is in 3 months, 4 months, 5 months. Not very good, but that's not unusual. If a child lives in a remote area and an ENT is nowhere close, and we have a lot of those situations, or something that's been relatively new over the last 4 to 5 years, the local ENT isn't accepting Medicaid, or they're not accepting new patients, or they're not accepting pediatric patients. We run into all 3 of those scenarios very frequently. We would consider that those are not reasonably available. So at that point, we do want to go ahead and make sure that the child sees a physician and that the form is signed off. What the otological is going to be doing, what the doctor's doing, is looking in the ear to make sure that there's not a being in the ear that's causing the child to be deaf, that there's not something in there that can be easily, oh, well, that would explain why he's got enough wax or whatever in there. That physician can sign that form in the meanwhile, but that is not to replace still getting to the ENT. So you still want to keep your ENT appointment that's in 4 months, take care of that, but that way you're not having to push off all of your timelines. If our students need services, they need services now, not 6 months from now. The second piece of the evaluation is the audiological. This one's done by an audiologist. Some school districts have their own audiologists, and they will do the audiological evaluation. Some do not, or maybe they have an audiologist, but they don't have a sound booth, which is often how our students are tested. In that case, then you go see a clinical audiologist, somebody at a hospital, somebody in their own practice. For eligibility purposes, this is also needed just once. You are determining the presence of a hearing loss. That's what you need for the disability component of that initial evaluation. Best practice is it happen way more often than once, especially if you've got a student who is using amplification. We really want this updated regularly. Make sure that there's no changes. The technology has gotten better and better and better throughout the years, and how our student used their hearing with a hearing aid when they were 5 may look very different than at the age of 12 because the technology is improved or their hearing may be going down. If you're not quite sure if you need a new one, ask the audiologist. And once again, it is the responsibility of the LEA to make sure that this happens. One question that we often get is that audiological report or the otological report or the vision reports that are not on the school forms. And we've got districts who will not move forward with any of the eligibility with the students because it's not on their form. Nothing in TAC or TEC says we've got to have this evaluation done on a school district's forms. What it says is we need the evaluations. Some of them have components like the audiological that is included in there. But the exam is the important part. And a lot of times what we get from the doctors or the audiologists is much more comprehensive than what's on our form anyway. The important thing is to make sure that the report that we get from the medical professional has that minimal information that we need. That's where that form helps us to be able to say, okay, these are the parts that have to be in there. But we can accept if an otologist or an otolaryngologist puts a note on a sticky note with a date in their signature and all of the required components, we can accept that. We're not recommending that. We hope that that doesn't often happen, but it could. If an audiologist, if a parent brings in what we call the familiar audiogram, which is the audiogram that has all those cute little pictures and it just shows, boom, that's what the child has, that is not enough paperwork. That's a great way of explaining to parents what a child's hearing, but that's missing most of the components. Okay, the last part of the eligibility for students who are deaf or hard of hearing for the DHH part is the communication evaluation. And the communication evaluation is done by, doesn't say in law who it has to be done or in code. Best practice is it's done by the teacher of the deaf and the SLP. The SLP brings in some of the language, some of the speech, some of those components that maybe the teacher of the deaf is not as familiar with. The teacher of the deaf often brings that sign language component of it that our SLP may or may not bring. This one does have to be done every 3 years to maintain the educational need. An IEP committee can do a review of existing evaluation data and decide that they do not need an updated communication evaluation. However, that is really very bad practice. And if you've got a 11th grader or 12th grader, maybe that's not as big of a deal. But unfortunately, I've been working with a few school districts where they did their communication evaluation at 5, and the student's now in high school and has never had an updated one. And I would really like to think that our students are communicating a little bit differently in high school than they are at age 5. Best practice is also that we be doing components of it annually for progress monitoring. Doesn't mean we have to do the entire thing, but what we really do want to make sure is that our students are making progress and that they're growing in their language and communication skills. The only way we're really going to be able to determine that is through assessment data. The question that we get most often with communication evaluation, remember I mentioned that whole Part C thing? Several years ago, TEA did away with that form as a requirement. Some IEP software still has the Part C communication evaluation form in there, but most of them don't. So what we started hearing is, there's no Part C form in our software, so we don't have to do a communication evaluation anymore. That is not true. Texas Education Code still says you do have to have that communication assessment component. The reason why that form disappeared is people were using it as the evaluation. Check, 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 NA, 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 check. And that was the evaluation. No implications, no narrative, no information about how that impacted anything. TEA said that's not enough. The requirement is to do that communication evaluation. And if you look through your FIE paperwork, there are all sorts of pieces where communication fits in, like pretty much everything. So any component of the FIE where communication impacts, there should be information in there about the impact of communication on that area. That's something that the teacher of the deaf, the SLP, should be working in collaboration with the diagnostician to make sure that that all gets in there. And then the communication evaluation does need to be written up in a narrative that can be added to the report as well. Okay. Stephanie, I'm going to turn it over to you.
That sounds wonderful. So, as we know, visual impairment is very much like deafness, hard of hearing, right? No, but we still have a lot of forms, a medical evaluation, it's similar, and the eyes and ears are close. So, no, we're going to go over visual impairment individually. And the IDEA definition of vision impairment is the term visually impaired includes blindness, and it means an impairment in vision that even with correction, that's important, even with correction, adversely affects the child's educational performance and includes both partial sight and blindness. So that means that the reason those words, even with correction, is highlighted is because that means that we can't determine the eligibility of a student with a vision impairment unless we know that they have correction. Because I've listened to a lot of lawyers present, and this is what's called a mitigating factor, and glasses are not a mitigating factor for vision impairment. That means we have to have those glasses and those pieces in place. Unlike in deaf, hard of hearing, where your hearing aids are a mitigating factor, and so you have to consider if they didn't have hearing aids, what their hearing would be. Vision is not that way, and hearing aids and glasses, they work very differently. So that's important. And then there are 4 assessments. So deaf, hard of hearing has 3. We have 4 assessments in vision impairment that have to be done in order to determine eligibility. All of these assessments are equally as important, but that does not mean that we don't need one before the other to move on. So an eye medical report from a licensed ophthalmologist or an optometrist. So that means you can go take a child to the Walmart optometrist to get this eye medical report filled out. Not best practice, not the best thing to do in most cases because they really need to see a medical professional. However, in a pinch, it can be used. And so that eye medical contains a lot of important information, and we'll get into that a little more later. A functional vision evaluation, and that can be done by either a TVI or a certified, and a TVI is a teacher of students with visual impairments, or a certified orientation and mobility specialist, or a COMS. Best practices for them to do it together. A learning media assessment, which is also done by TVI, and then an orientation and mobility evaluation is also a requirement for initial eligibility for every student, which has to be performed by a certified orientation and mobility specialist. So when we look at the eye medical report, I've included a picture here. You're not intended to see it, but usually those stars and things that are on it stand out. There are a few versions. This is the most recent one. However, we do expect it to go through another change this year. But right now, this is what we have. The form, like Susie said, is not a requirement. The information that's in the form, especially the start information, is a requirement. This form was put together out of an interagency committee that included the Texas Workforce Commission, Health and Human Services, and other agencies that work with students with visual impairments to make sure that we have the most comprehensive data available in order to make eligibility determinations, not only in the school, but also for all of those additional services that they may be eligible for as well. So this form has to be filled out by an optometrist or an ophthalmologist. So a medical doctor, the child's pediatrician, the neurologist, those are not acceptable doctors to complete this form. It is required for eligibility, okay? I'm gonna say that again. It is required for eligibility, not required before, like before you do anything else. But if you don't have a medical report that shows that the student has best corrected vision, you may be repeating some forms of your evaluation. Much like as a diagnostician, if the child has not passed their vision screening at school, you make sure that they have glasses and their vision screening is passed before you move on with your assessments. Our teachers of students with visual impairments and our orientation and mobility specialists also want to ensure that they have the best, most accurate data to move off of. And so they will need this report before they start their reports as well, or else they may be spending a lot of extra time doing evaluations or pieces of evaluations that may or may not be necessary. The other piece of this is that the eye report, it is important that we update those pretty regularly because many of you know this because you've been through it yourself. Eyes change, they grow, the shape changes, how you can see changes. That's why when we get glasses and contacts, we're required to go every year or two to get new evaluations before we get new glasses or contacts. That's because vision fluctuates that often and changes that much. My own child, his vision changed in the middle of the year. I had to go get him. His glasses only lasted 6 months when he was going through big growth spurts. So those are important things that also occur with students who have significant visual impairments too. So we want to make sure that they're having that updated regularly. And then the other piece is that because this is a part of eligibility, it is the fiscal responsibility of the local education agency to obtain this report. That means that your timeline, you have to get the report within the timeline. You are responsible fiscally for obtaining that report. The good part of this is typically by the time we have that concern for a vision impairment, these students have been to see an eye care professional for glasses or for something else, a red flag that came up, and parents have taken them to see eye care professionals, and we can obtain this report from a previous visit. But if we can't obtain the report from a previous visit, we still have to get that piece in order to have a full range for eligibility. And it is the responsibility of the LEA to do that. There are also some important things that are changing in the Texas Administrative Code about iReport and what needs to be included on them. So previously, there was a piece of the iReport that said that the student has a significant vision impairment. OSEP has come in and said that there is no qualifying statement on IDEA's guidelines for vision impairment, so we cannot have the word significant in our code. So we're expecting in January for that code to be updated and go into effect, and for that significant piece to be taken out. So that will also trickle down. It will change our iReport a little bit. It will erase one word, but that one word being erased in the iReport is going to have quite a bit of impact on our field. And it means also that you need to partner with your teacher or students with visual impairments even more than you were doing before, because they are your expert on being able to really read these iReports and to talk you through that, the pieces of what impact these things would have on a student's vision as you're moving forward. And they're going to be able to help you navigate this iReport, because it's going to be a little bit harder to read with that code being updated. So the next evaluation that needs to be done is a functional vision evaluation. And so the first picture on this page shows what functional vision kind of looks like in eSped. It's very short, check boxes, and includes very little information. If Susie will hit that button again, you'll see what a written up report is. And typically this will contain much more information than what is required by law to minimally be assessed for students. So either a TVI or a COMS, so that is either a teacher of students with visual impairments or an orientation and mobility specialist, they can both fill this out. It is actually best practice and recommended that they do it together, because they each have different strengths in looking at vision. Your orientation and mobility specialist is going to be very good at looking at visual fields and distance vision and things that are going on in that realm as they're traveling. And your teacher of students with visual impairments is going to be really good at looking at their functional vision amongst different lighting conditions, environments in the classroom, how far they have to sit from the board or how close they might need to sit to the board to do things. So that's important. The other thing that you may have noticed, especially if you have a student with a visual impairment that you've been evaluating recently or have ever evaluated, is that every 3 years, your teachers of students with visual impairments will ask to update this evaluation, sometimes more often than 3 years. But that goes hand in hand with your iMedical report in saying that not only do kids' vision change, but the environments that they're in changes. So you may notice, especially if you serve kids in multiple environments, that a junior high or high school looks very different and the environment is very different than like an elementary school. There may be stairs, there may be other things there. There may be differences in lighting or class size, the work that they're doing, all of those things. And so it's very important for us to update this as vision changes or as we see concerns with visual changes. It has to be done legally in multiple environments, near and distance, and our teachers of students with visual impairments and COMS, they must address the need for what's called a clinical low vision evaluation. So a clinical low vision evaluation is another type of medical evaluation that looks at the need for prescriptive low vision devices for students. So much like you have glasses at a prescription, that clinical low vision evaluation is going to look at prescriptive magnifiers, monoculars, those different needs of a student as well. I think we talk about it more later in the presentation. So a TVI or a COMS in the functional vision evaluation recommends a low vision evaluation. Isn't that what the eye doctor said? Technically, no, it's not what the eye doctor did. In fact, a low vision evaluation takes more time in the office. It is more functional in nature, but it is very prescriptive on those devices. So we recommend to our teachers of students with visual impairments that they go with the student and parent for that low vision evaluation, that they actually take curriculum and materials that are being used in the classroom with them to the eye care professional that is doing this evaluation so that they can help make the best recommendations for those different materials. We're putting together a toolbox of assistive technology that can be used because a monocular that's used for distance viewing is very different than a magnifier that's used for near viewing. And it's very, very important that we have the right prescription for those moving forward. And your teacher of students with visual impairments can't determine that prescription. It has to come by a medical professional. And so that's why we have it in code that way. All right. The next is the learning media assessment. Just like the other one, I'm not particularly impressed by any of our online software programs because they're all set up to really follow what's in code for a learning media assessment, which is actually very minimal compared to what we do. And so you will see something similar, checkbox boxes and things like that in the form online, but hopefully your teacher of students with visual impairments will actually give you something that looks like, Susie will hit the button there, it'll show us. There we go. A written up narrative report that contains a lot of information, because this learning media assessment should identify how this child learns best, what learning media, print, braille, what low vision devices need to be used to access those things, what all of that has to kind of interplays together and goes into this wonderful evaluation. Typically, diagnosticians really love the information that's in these evaluations because it's just very good information and very supportive of any accommodations or modifications that are needed in the classroom. So this evaluation can only be done by a teacher of students with visual impairments. It is another evaluation that really needs to be updated every 3 years, or when vision changes or when the educational needs of the student changes. So we have to do evaluations to determine our accommodations, our modifications, to update the needs, to update and defend what the needs of the students are and why we're going in those directions. So this is another one that when you're doing things and your TVIs are saying, no, I can't just pull forward my evaluation date. I really need to do an updated evaluation. They are speaking the truth. It's gonna give you a learning and a literacy medium. So literacy, we really focus on, is it braille or print or tactile symbols, something to that matter? How are these students going to independently read as much as possible? Whereas their learning medium is going to really look at, how do they learn best? Are they an auditory learner? What's their primary channel for getting information? Those may not be the same thing. And especially with young children who are learning new things, those may not be the same thing. They have to address the need for ongoing evaluation if that is necessary. So especially for students who are young in literacy, there are a lot of changes that happen between kindergarten and 3rd grade in literacy instruction. And one of the least significant changes for most students is just the print size that changes in their textbooks. It goes from a very large print in kindergarten when they're learning to read with lots of space between words to a much smaller print in 3rd grade in textbooks and those things with less spaces between words and lines. And so there's a big change that happens there. And we may need to continue to update this evaluation as we go. Or there may not be a learning or literacy medium that is significantly better than another, or they may be learning one. So that's important. The other thing we must address for every single student with a visual impairment, regardless of how significant that vision impairment is, we must address their need for Braille. So I'm going to say that again because that was a recent change in law. We must address for every student with a visual impairment, the need for Braille. Okay, so this includes your students with 20/70 vision, low vision, who can read print. We still have to address, do they need Braille? And it has to be based on a really comprehensive and good learning media assessment. Okay. The next and last part of this evaluation is orientation and mobility. So again, we've included one picture of orientation and mobility. Hopefully the write-up will be much more significant in orientation and mobility than the online forms are. An orientation and mobility assessment can only be done by a certified orientation and mobility specialist. Okay? They have to do it legally, but in multiple lighting conditions, in the home, school, and community. They have to address all 3 areas: All three areas may not be appropriate for all students, but they have to address, can they orient and get around home, school, and community? It is a part of every single initial evaluation. We run into some problems with this, especially if we get in and we're evaluating a student who drives, which happens, believe it or not. And they still have to do an orientation and mobility evaluation. So we have to make sure that every student who is going through this process gets that evaluation. Sometimes school districts don't even have an orientation and mobility specialist that works for them full time, and this has to be contracted out in those instances. And then the other piece of this that is so very important is law changed about, it's been 3 or 4 years, I think, that the only person who can make the determination if an orientation mobility evaluation needs to be updated or needs to be done again at any point in time is that orientation and mobility specialist. They are a part of that child's committee after that first evaluation. They are a part of that child's committee ongoing. And so every time you're looking at evaluations, even if they're not serving the student currently, you still have to consult with the orientation mobility specialist to determine if they need an orientation mobility evaluation. And again, that can change based on the age of the student's environment, the school they go to. I mean, I know that when I was going to school and when I was teaching, my elementary schools didn't typically have a lot of stairs in them, but we had 3 floors when I was in high school. And so that is a significant amount of stairs. And that's a significant change in how you travel or learn a classroom. So those are important things to remember. Susie, you are muted. But she's going to talk about deafblind coming up.
Okay, thank you. We're not going to spend a whole lot of time on deafblind because honestly, the pieces that we just went through, a lot of them, well, all of them, apply to our students who are deafblind as well. So this is the federal definition. That means that there's both hearing as well as vision loss of some sort, that because the two of them are combined mean that there are deficits in communication, some developmental educational needs, something that if you only provide VI services or only provide DHH services, the needs of the students are not going to be met. And with that, that means that there are students who might qualify as deafblind who might not qualify as being deaf or hard of hearing, or might not qualify as being a student with a visual impairment. There are 4 different ways in Texas that we qualify students to be deaf or hard of hearing. So the first one here on the right, this is a kind of a chart, a beautiful something that we made that talks about all of the different ways. The first one is eligibility for AI or DHH and VI. If the student qualifies as blind or visually impaired, qualifies as deaf or hard of hearing, they automatically qualify as deaf-blind. On the eligibility paperwork, you do not have to put AI, VI, DB in PEIMS. If you've got DB, you don't need AI, VI at all. Another way is this combination that alone might not meet criteria. So I think about one of my students who was deaf-blind after he pulled a TV down on his head at the age of 2. And because of where it hit in the brain, it impacted his vision and his hearing. But only the right eye and the left ear. So he had no vision in the right eye and typical vision in the left eye, which normally would not qualify as a student with a visual impairment. But then his opposite ear had hearing loss and typical in the right. Students who are deaf or hard of hearing, sometimes we do qualify them if they have a unilateral loss or a mild loss, Vision, not normally so much. But thinking about this student, whenever he needed to hear, he turned his good ear, but that's his bad eye. He can't see out of that one. Or vice versa. You put the two of those together, and he's a student who really has a lot of access concerns, even though if he just had the visual impairment, he might not, if he wasn't deaf or hard of hearing, he might not have qualified as VI and may or may not have qualified as deaf or hard of hearing. The third way is if a student has a progressive hearing or vision loss. In special ed in general, if we know that a student may or may not be worse later on, we don't qualify them for special ed. It's looking what they are now. When we start looking at vision and hearing, if there is progressive, we qualify them, because that's not a maybe, that is a happening. The most common one of these are a student who is deaf or hard of hearing and is diagnosed with retinitis pigmentosa, which is a vision concern. That is Usher syndrome. And these are students who begin to have problems seeing in the dark, and the vision starts coming in. And so it's not unusual for our students who have Usher syndrome to not have been diagnosed when they were younger, to get identified maybe middle school, high school, depending on the severity, and depending on the severity again, and at what age they were diagnosed, they may end up with completely no vision to go along with that limited hearing already, or definitely very limited, like if they're looking through a straw. Those are students that we would qualify immediately, as soon as we find out. Then the fourth way is kind of a strange way. This is a student who meets the criteria as visually impaired, but the hearing is inconclusive. This could be either because the student isn't consistent with how they're responding, or that because to get a decent or an accurate hearing assessment, the student would have to be sedated to do an auditory brainstem response. And a lot of our students with significant medical needs, they don't need to be put under sedation to be able to test the hearing in this case. So if we have an SLP who agrees that there's no speech at an age where they should be, the child's eligible for VI, and the hearing is inconclusive, then they will go ahead and determine that they would qualify. If you're looking at a 6-month-old, I would have to say that no speech is probably not going to be a concern. A 6-year-old who is not talking, a speech therapist may determine that there is a concern. I was going to say something else, but I'm not going to. Go ahead, Stephanie.
That's okay, Susie. Your explanation made me realize that there was something I didn't address on the I report dealing with vision. And so immediately, as soon as you said, we would typically, a student wouldn't qualify if they only had vision loss, even no vision in only one eye. And I wanted to explain that just a bit to everybody.
Please do.
So vision is a little different, and yes, we use our eyes together a lot of the times, and they overlap. Our vision out of each eye overlaps so that we have depth perception. But your eye, you don't lose vision starting in the middle and going to the sideway when you lose vision in one eye. We actually have quite a bit of peripheral vision and can see quite a bit well with vision only in one eye. In fact, you can drive if you only have vision in one eye. 20/20 vision is 20/20 vision. Your brain adapts. There are some things that may be concerns for people who have only vision in one eye, and those are things like approaching them from the side really drastically, or throwing balls at them from their bad eye side. They may miss that coming at them from the side. The other piece that they may miss is some depth perception issues. But those are things that there are accommodations for that can be put in place, which is why typically they don't need specially designed instruction, because they actually can see most of what they could see with vision in both eyes. And so there are a few things we have to go around and do some things. So I wanted to explain that because it might seem weird to some people.
That's a very, very good point. With that in mind, a few other things that I want to touch on with deafblind. I'm going to jump back to the communication evaluation, which we said needs to happen with the TOD and the SLP. If we have a student who has vision loss, guess who needs to be involved in that? Teacher of the visually impaired needs to be able to consult with the group, because if you're looking at sign language, how far away can that student see sign? What does the lighting need to look like? What does the peripheral need to look like? It's not unusual for us to put our students who are deaf or hard of hearing at the front of the room, preferred seating, because they can pick up some hearing that way. But if you've got a student who has this much vision, still good vision, but very limited, they're going to do better at the back of the room than the front of the room. So these are the type of things that the teacher of the visually impaired needs to be involved in to make sure that we're getting the correct information in there. The other part that we need to make sure that we are collaborating is that learning media assessment. Do you know how many students I've had who are profoundly deaf that came to me with a learning media assessment that said that auditory is their primary channel? Because they had no vision, they didn't use tactile in any way, but they jumped every time there was a loud noise. So, ta-da, that's their learning medium, which may be the case, may not be the case. But if we're not collaborating, we don't know. Stephanie, did you want to add something else in there?
I was going to say the learning media, you read my mind. The learning media assessment also needs to be done collaboratively. But then I was going to say that actually is a wonderful segue into our next topic area, which is a comprehensive assessment. And the fact that when you have a student who is visually impaired, deaf, hard of hearing, and or deafblind, you really need to have everybody on board and participating and helping out in those evaluations, because we can't operate in silos.
Yeah.
And so as a diagnostician, you can't do your evaluations without the help and support of the teacher of the deaf, hard of hearing, and the teacher of the visually impaired. They provide profoundly important information for you before you do any type of evaluations, including just classroom assessments and benchmarks.
Exactly.
So I just thought that was great.
Well, one thing that I want to say about that collaboration before we jump into the comprehensive is the orientation and mobility. And this is kind of a strange one, because we tend to think, why would an audiologist need to be involved in an orientation and mobility evaluation? If you're not familiar with the way hearing aids work, hearing aids make things louder. They don't make things more clear, they make things louder. Some students can use the hearing aids and turn their head to realize where the sound is coming from. Some students, the hearing aids are not helping with that. The other piece of hearing assistive technology we tend to give our students are called FM systems or DM systems, where the teacher's using a microphone and that sound is going straight into the hearing aids or the cochlear implants that the child's wearing, which is great. Means communication is happening. But what we're doing with that is we are suppressing all that background noise. If I'm in a classroom, I want it suppressed. I don't want to hear the air conditioner or the grass mowing or the kids sharpening their pencil. If I'm crossing a street, I want to be able to hear those sounds. If there's a dog running towards me, I need to know that. And so the audiologist is the one that really needs to be working together with the orientation and mobility specialist to make sure that the hearing technology is meeting the needs of that orientation mobility specialist in the skills that they're teaching the students. That tends to be collaboration we don't always think about, but it's a very, very important one, and one that we're really doing a lot more at focusing and training on. So.
Well, and I will tell you that a lot of times your orientation and mobility specialists may also pick up on hearing concerns when they're out in the environment and doing lessons with students, because they are unable to hear things that they typically should be able to hear. And so there have been times, quite a few times, that an orientation and mobility specialist has brought up a hearing concern for these students. And I think that's important, because collaboration on these assessments for these students is the most valuable piece of information that you have, is just talking to each other and understanding as much as possible how these students gain information from the world around them.
Exactly. I agree. Okay.
All right. And that leads us straight into a comprehensive assessment. And what does that consist of? Oh, dear. This is the hard question that Susie and I both get asked with vision and hearing frequently. I often get asked, what are the magic check marks or the magic words that are on the iReport that initiate a concern in vision that will start the evaluation? There aren't any magic words. There aren't any magic check marks. I can't tell you that vision conditions, they start at 2070, and that's when you should start considering if they have 2070 or worse vision. That's not necessarily the case. It is their functional use of vision, and neither IDEA federal code or our Texas education code or administrative code, none of them have eligibility cutoffs for vision or hearing.
Exactly. It's not unusual for me to get a call from diagnosticians wanting to know, and they want to know how to read the audiogram so they know whether or not they should refer this student on. And I've had students with a mild hearing loss who didn't use their hearing near as well as one who had a more significant loss. It all depends on how they use it. The same with vision. Stephanie talked about how a student with vision in one eye most likely is not going to qualify unless there's also some limitations in the other eye. Students who are deaf or hard of hearing who have one ear, what we know is that they are 10 times more likely to be at risk for educational delay. And a student who has a mild hearing loss as well. Students who have ear infections recurrent, 50% of them or more, or 50% of them or so, have mild hearing loss. So it's just an ear infection. Not going to do that. What I tell diagnosticians when they want to know about reading the audiogram, I am happy to teach you to read an audiogram, but it's not your responsibility to interpret it. Just like it's not my responsibility to interpret the diagnostic examination that an LSSP or a diagnostician is going to do, but I can read it and think about how it impacts me. It's not, as educators, as diagnosticians, it's not our responsibility to interpret the audiogram. We need to have that in there, and we need to ask what those implications are.
So this particular slide came out of TEA's Child Find and Technical Assistance document. And you may be asking yourself, well, if there's not a magic number, how do we know? Where do we get this information? How do we know if they qualify under deaf, hard of hearing, or visually impaired? And so the first thing we have to do is determine, is there a disability? Is there an impairment in their vision or an impairment in their hearing that is affecting them? And that's part of why we have both the medical diagnosis as well as all of our functional evaluations to really look at communication, vision, all of those pieces in a real life environment. So once that is determined, then you have to consider, as a result of that disability, is specially designed instruction needed? Or does the student need special education and or related services? And that I shouldn't have said and or, it's and related services. And the other piece of that is when we're doing reevaluations, it's important to note that even though it may not be necessary to update those evaluations to determine eligibility, which is one purpose of an evaluation, just the primary one, to determine if a child is a child with a disability. Then, oh, this isn't the slide I thought it was. So, what we do need to do, let's go ahead and go to the next. It's fine. I just wasn't paying enough attention. So, what we do need to do in looking at that evaluation is look at information. We may need to update evaluations to determine whether a child's educational needs have changed, and therefore their accommodations and modifications need to be updated. And so that is the reason why in deaf, hard of hearing, as well as vision impairment, we really preach, we preach that those evaluations need to be updated every 3 years, and sometimes more frequently than every 3 years. And then it's also to just guide our decision making about the appropriate educational programming of the child. We shouldn't be making decisions that's not based on data that we've collected. And the way we collect data for students who are deaf, hard of hearing, and visually impaired are through these evaluations, the learning media, the functional vision, the communication evaluations. Sometimes even the audiogram needs to be updated, just like the eye report might need to be updated, just to show that there are fluctuations or changes, things that happen with a student's hearing or vision. So those are important reasons why we update those. And then we talked about this because we led into it with deaf blind. It's essential for the teacher of the deaf, hard of hearing and or the TVI to be a collaborative partner in all evaluations, to provide information related to individualized assessment procedures and assist in interpreting the results. A lot of times we get a hand raise at this point and somebody says, but I give a test that has validity and reliability, and I can't change how that test is delivered. Nothing, because it will take the validity of the test and throw it out the window, and it will no longer be valid and reliable. Guess what? These tests that you typically give as an educational diagnostician or an LSSP, even the assessments that we give in classrooms, the benchmarks, they're not normed on students who have visual impairments or who are deaf, hard of hearing, which means, guess what? Your test, it's not valid and reliable data for this group of students to begin with. And it's even less reliable if you do not do it with accommodations. You're not going to get the data that you need to make educational decisions, which is the purpose of the assessment, if you don't implement the accommodations that are needed for each student. So just know that, yes, we understand these tests aren't normed. You're not going to get reliable, valid data from them, but that does not mean that you will not get information that can support and guide decisions of the ARD committee in determining educational placement and programming moving forward for these students. They are still very important tests. It just is also important to realize that we're talking about the 1%, some of the smallest population of students that are out there in the field of special education, and it just is impossible to make reliable norm tests for our group. Susie, you want to add to?
Pretty much what she said. We got together Woodcock Johnson gathered together a think tank of professors, specialists in evaluation, all sorts of people from all over the US came to Texas Women's University, and I got to sit and lurk in that, and it was awesome. It was a week long. We talked about the variety of students, talked about how we could norm a test. And at the end of that week, the determination was there is no way that we could norm a test, because not only are we just 1%, our students are so diverse within that 1% that there's no way that we could norm. And that really our time and energy needs to be spent on talking about what you do with those assessment results, how you can write them up in a way that they're functional, how you can use the results that you've got to compare with your same age peers, but at the same time recognizing when are you testing hearing or testing vision versus testing the skill. It was a fascinating, it was something that we all had known, but to actually get the gurus in the field all together was fascinating. And as somebody who's worked in the field of visual impairment, deafblind as well as deaf, I know it's the same thing with all three of the groups. Very, very diverse. One thing that we often hear also is once the TVI has done their assessment, the TOD has done their assessment, well, is this child going to qualify? We can say this child meets the eligibility as a student with a visual impairment or who is deaf or hard of hearing, but we're not the one who determines that there's specially designed instruction needs. So we don't decide whether a student is eligible for special education. That is done by the ARD committee. All of the people who are part of the assessment team can say, this student may have a learning disability. This student has a visual impairment. This student has an orthopedic impairment. But until we get together with that ARD committee, we can't say, yes, that impacts their education adversely. That's, yeah. And with that in mind, we often hear that, well, he's GT, so he can't be blind or visually impaired or deaf or hard of hearing, or he's deaf or hard of hearing or blind and visually impaired, so he can't be gifted and talented. Or he's getting straight A's, so why would he qualify for special education? And the reality is he may still. OSEP, the Office of Special Education Programs, wrote a letter to a district. Somebody wrote and said, hey, they dismissed this child because he was making straight A's, but the speech impairment is still gone, it's not gone away. And what OSEP said is that just because a student passes all the courses, advances from grade to grade, doesn't mean that he's ineligible for special education services. And that's an IDEA as well, that as we are looking at educational need, we cannot just look at the student's grades. And that we've got to be looking at more than a child's academic performance. We know that eligibility requires that there is an educational need for services. The problem is sometimes that educational need is interpreted as academic need. And IDEA defines it as academic, functional, and developmental. And if we are not looking at the functional and developmental pieces of this, then we are missing a huge part of the child. Do you want to talk about this one, Stephanie?
Absolutely. So one of the things that we get asked a lot is, do we really have to have the teacher of the deaf, hard of hearing and the teacher of the visually impaired at every ARD meeting? Even if we're discussing, let's say manifestation determination or transportation changes, do they really need to be a part of that? Guess what? Yes, they do. And part of why they are a required member of every ARD committee, not only, and I'm going to say this, and my teachers of the visually impaired who are overwhelmed and swamped right now might kill me, but I'm going to say it anyways. The TAC code, the actual code that's in law, says that the teacher of the deaf, hard of hearing and or the teacher of the visually impaired should be a part of the ARD committee if there is a suspected or documented vision impairment or deaf, hard of hearing, or deaf blind. You should really have both of them. And where it gets hard is that suspected or documented. So that means that even if you as an ARD committee are coming together and you're going, we think, we suspect, or we received this eye report, or we received information from a doctor that says there may be some type of vision concern going on, guess who should be a part of those meetings, helping you make those determinations? Should be that teacher of the visually impaired and the teacher of the deaf, hard of hearing. Are hearing and vision services instructional or related? And does it make a difference if they are consult services or direct services? It gets really complicated, doesn't it? So in code, it actually refers to, and you can remember this because their names start with teacher. Teacher of the deaf, hard of hearing can be direct or consult, but they are instructional because they are teachers. Teacher of the visually impaired are also required to be licensed educational professionals. They're teachers. And so they're also instructional, and they can be either direct or consult. Orientation and mobility specialist, their certification is a national certification like PT, OT, speech, those types of things, and they're not required to be teachers. They are related service professionals. And then I'll let Susie talk a little more and go more in depth into interpreting and audiological services because she is the expert in those areas, but they are also related services.
They are. IDEA has a whole list of what is considered a related service. And interpreting, while we know that it's a support in, it is a service in support of instruction or a support and aid, it does count as a related service, which means that we have to have a frequency, a location, and a duration. One thing that we often see is the student has 360 minutes a day of interpreting, and then they have 180 minutes a day of the teacher of the deaf. What that means is that there needs to be an interpreter in with the teacher of the deaf. We can't just say student needs interpreter all day long without actually looking to make sure that the student needs that type of access all day long. The other thing that gets confusing is audiological services versus audiological management. IDEA defines audiological services. Somebody dropping off equipment, picking up equipment, checking the batteries, making sure everything's working is not in the definition of IDEA. I'm not going to spend more time on that, but just something to know. Because what we often hear is, well, how can we put frequency, location, duration on they're coming to check on the hearing aids? If they're coming to check on it, it's not a related service.
Well, and I want to go back to just make sure that everybody understands that orientation and mobility services are services that are provided specifically for students who are visually impaired. So there is this thing called travel training out there, and those are special education services, and you should be a special education teacher in order to deliver those services. And as I noted, orientation and mobility specialists do not have to be teachers. And so it is in IDEA specifically that those services are delivered to students with visual impairments. So you can't receive orientation and mobility services and not be identified as a student with a vision impairment.
Okay, so I went to go visit a school district one time that was in trouble because they had DNQ'd. They didn't qualify all these 3-year-olds who were deaf or hard of hearing, but then they picked them up again when they were 5. It's like, well, why not? Because the students didn't need a self-contained special ed classroom for 3s and 4s. So they DNQ'd them and picked them up again when they started school. Well, they kind of got in trouble for that, surprisingly enough. So then I started finding that there's more and more districts who weren't quite sure what to do with that group. What services can we provide to 3 and 4-year-olds if they're not going to be attending public school? The Student Attendance and Accounting Handbook clarifies that if a student is 3 or 4 years old and is enrolled in a private preschool or a private daycare, they can also enroll in the public school and receive those services as if they were a public school student. Kids 5 and above, then we start getting into proportionate share and private school stuff. 3s and 4s doesn't count. as long as they're enrolled in the school district as well as enrolled in that private preschool or daycare. If the parents are not willing to enroll them in the public school at all, then we start going private school, proportionate share, that type of stuff. If a student is staying home with their parents, with the grandparents, they're not going to a public or private daycare or preschool, they still can receive services in the home, kind of continuing what they got from ECI for vision and hearing. They're still counted homebound, but we don't have to have the doctor's note. They're not considered homeschooled, so we're not following that. Those services would continue. Please do not DNQ your kids if they're too high. It's what I keep hearing. They're too high for a PPCD classroom. Well, you know, we don't have PPCD classrooms. We have special ed self-contained preschool classrooms. Not all campuses have 3-year-old Head Start or 3-year-old pre-K. And if that's the type of setting a student needs, we don't just drop the kids and pick them up later. So our favorite topic, special factor supplement. That is a requirement in every IEP meeting. And it's in federal law that the IEP team has to consider the DHH factors, the VI factors, anytime they work on the child's IEP. Technically, it's referred to as the special factors. In Texas, we call that the VI supplement, the DHH or AI supplement. It's required. And it's updated information that drives the development of the IEP. When we start looking at the DHH special factors, it's all about language and communication. How is the student interacting with peers? How are they interacting with professionals? Do they get direct communication where they can sign directly to that person? Or is everything done through an interpreter? What does their academic level look like compared to their peers? And are all of their ranges of need taken care of? If we save this for the very end of the ARD and we go check, 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 then we are not considering all of these as part of their IEP. This is something that needs to be discussed right after the PLAFs or with the PLAFs, and then we use that to drive the whole rest of the IEP meeting. One question that we get related to that is the RDSPD, that Regional Day School Program for the Deaf. Those are our cluster sites where we tend to send our students who sign. And so one of the questions we get is the student doesn't sign. Why would we recommend a student doesn't go there? And that is because we have to make sure that the student's unique communication mode is developed to the appropriate level of proficiency. And sometimes our students who aren't using sign need a lot more intensive language acquisition services than they would be able to get on their home campus in their home district. So we need to make sure that as we are determining placement, it's not just based on, well, they're deaf that they go there and they're not deaf so they don't go there, or they sign so they go there and they're not signed that they don't go there. We can't do that. We have to be discussing all of these special factors to determine where that student can best have their communication needs met.
Right, and the VI special factors. This is a form that that needs some update, but it should be a really valuable piece of information as we discuss things. What's required by law is that we make sure to address community services and resources, arrangements for the evaluation of the impact of the impairment and instruction in the expanded core curriculum. So there are 9 areas of the expanded core curriculum that include compensatory skills, which includes Braille, concept development, and other skills that are needed to access the general curriculum, orientation and mobility, social interaction, career planning, assisted technology, including the use of optical devices, independent living skills, recreation and leisure, self-determination, and sensory efficiency. These are 9 areas that have been determined at a national level are impacted by a student's impairment in vision. These are the areas that your teacher of the students with visual impairment teach in. This is what they've been trained to do. They have been trained to address these 9 areas of the expanded core curriculum. So this really is necessary for them to update and to address every year. It's needed before you even get into the goals section. Like Susie said, right after the PLAF, it really is an extension of your PLAF statement. A lot of times the expanded core can also be addressed in the PLAF, as well as on the page in your IEP documentation software, especially if that page includes check marks, boxes, and drop-down menus. It's really important that we really narrate where these kids are in these 9 areas. The other piece that's important to include on here is to address beyond school hours. It's very often that our students with visual impairments, because they have these 9 other areas, need additional services outside the typical school day so that they can not only get their academic information and their core class information from the school day, but they also have sufficient time for support in these 9 areas of the expanded core curriculum. So I know that there's no other student out there where you have to say, hey, are we doing O&M at night? Are we doing Braille before school? Are they meeting with their teacher of the visually impaired at a time that's not during the school day so that they're not pulled out and missing that class time and that instructional time? Very important, especially for your academic students. The other part of the special factors is addressing Braille. So I did this earlier. I'm not going to go too into depth, but make sure for every single student, we're addressing the need for Braille. And then remember, when you're trying to determine, does this student need special education services as a result of an impairment in vision? Are we considering things like Braille, orientation and mobility? Does their vision impact those 9 areas of the expanded core curriculum? Because that is the area that we give specially designed instruction for these students. Yes, they may also need support in reading and support in other areas, but is that a result of their impairment in their vision, or is that a result of maybe another disability that's going on? It becomes an important conversation that you have at the district level when you're talking about suspected vision impairment. What do we really suspect that the child is struggling due to vision, or do we suspect that vision may be playing a factor, but there really is something else going on? And we need to have those discussions, even if we're not able to tease out those pieces. And those discussions really need to be had before you make that referral. And you need to have them not based on an individual student. You really need to, as a district, talk about what does it mean to be to have a concern in vision or to have a concern in hearing. It's not necessarily, hey, these kids might need glasses, because then they don't need specially designed instruction. They need glasses. And then they can access their instruction through that. And then if you gave them supports while they couldn't see, while they were getting their glasses, you have to give those supports again because they didn't get that information visually. And that's important to know. You want to make sure that those glasses aren't helping their vision enough. And you want to give them time to make up that learning that they may have visually missed during that time where they couldn't necessarily see the board or read the reading materials that you were putting in front of them.
Exactly. So one of the things that we have set up is a community of practice. And this is a learning management system that has online courses. It has networking groups, discussion groups, and we have discussion groups that are specifically for diagnosticians and LSSPs who work with kids who are blind or visually impaired, or work with kids who are deaf or hard of hearing. We encourage everybody to come and join the conversation. Look to see what online courses that we've got. Many of them are a simple 1 hour long or less. We're continuing to add resources on a regular basis. Come and find out what your peers are doing. There's not a lot of conversations going on in the assessment groups because there's not a whole lot of people in there, but those are the people that you want to network with. So we highly recommend that you come and join us. We do have a QR code for this one that is different than the one in the live binder. However, the community practice is linked in the live binder. And the URL for this is txssn.org/COP. And that will get you directly to our community of practice. And we strongly encourage that you come and play and learn. And, we talked a lot about that whole collaboration piece. While Stephanie and I combined have more years of experience than really we can count, than either of us have been alive, the reality is we don't know everything there is to know about everything yet. Someday maybe we will. But meanwhile, we have to play well with our friends to learn from our friends and to learn with our friends. So with that in mind, this is our contact information. Both of us are located in Fort Worth, housed out of ESC Region 11, but we serve the entire state. We are experts at Zoom by now. We Zoomed before everybody else Zoomed because we served the entire state and they wouldn't buy us a helicopter for us to travel everywhere we needed to go. We do encourage you to reach out. Touch base with your education service center. If you've got questions, talk with their regional VI, regional DHH person, or reach out and talk with us. So this is the time where we would ask if y'all have any questions, but nobody's here to ask questions.
But they can go ask questions in the community of practice.
What a great idea, Stephanie. I think that's a good idea. We did try and build in a lot of the questions that we know that we normally get when we talk about this. So come play with us, come learn with us, and enjoy our kids because we sure do. Thank you very much.
Have a great day, afternoon, morning, whatever's left of today.
Exactly. Bye.